Good evening. I'm Professor Ian Hickie, the Co-Director of Health and Policy at the Brain and Mind Centre, and I welcome you to the second of our seminars on transformation in mental health and on particularly the digital future. This particular session tonight is focused on mental health systems. And one of my preoccupations over the years, to waitlist or not to waitlist. And so it's about no more waitlists. I'm joined by a large group of people here this evening. Professor Joanne Atkinson, Danny Rock, Mike Millard, Shane Cross, Liz Scott and Angelo Virgona to discuss these particular sets of issues, each working in different parts of systems, each working with new and models of ways of delivering care for the future. I'd like to recognise the traditional owners of the land on which we meet, the Gadigal people of the Eora Nation, where Sydney University is based, who've dealt with these issues for generations, and some would say in many more productive ways than we do today, at least from a whole system perspective, that there is no person in isolation. People are part of systems, and how systems function often determines the health and welfare of the individuals. I'd also recognise those with lived experiences in these areas and many of the people who have been through our systems and also many of the providers of our systems over time. Everyone in this particular webinar is devoted to a better system that individually we all think we're good. I discussed it in the afternoon. I think this is the best psychiatrist in the world, but even she maybe cannot deliver best care in dysfunctional systems. A long time ago, in fact, more than 25 years ago, I was part of a movement that tried to get mental health to adopt waiting lists. It always seemed to me politically dumb, compared with surgeons and compared with hospitals, that we were not prepared to say who was waiting for care. We often define people as not requiring care or wouldn't specify what were the interventions that were being postponed as a consequence of actually not recording them and not saying what the delay was or who was not receiving care. Just this week, I've been challenged about whether we can even collect data in mental health, put that into systematic models and talk about systems of care. But as pointed out, and in discussions with Danny Rock and with others in this particular teleconference, my real preoccupation at the moment is actually, why should people have to wait at all? In the 21st century, when we are able to provide access to so many different sets of services and options and meet people's needs where they are, why are we still even talking about waiting lists? Surely with the digital sets of systems we have, we can do smart things as in any other service industry to meet different levels of demand as they happen. Right at the moment, of course, people in this particular world will be aware that COVID-19 has completely transformed our delivery of services and that there are now going to be, as a consequence of the economic and social dislocation, very significant increases in demands for services, and the danger is very significant increases in poor outcomes, including suicide, as a consequence of these issues. So the challenge to us now is greater than ever. As we go through tonight, you'll notice the Q&A function down in the Zoom corner. Unlike our previous webinar, we had a lot of speakers covering a lot of topics. If you want to disagree, if you think that what you're hearing is complete nonsense, or you have specific questions, or you'd like to challenge me in particular, or any of the other presenters, please use the Q&A function. I will try to interrupt and seek clarification and hopefully be provocative myself along the way. So we perhaps be more interactive than we were last time and more responsive to the particular needs that people actually have and their questions, their comments, their input, since you've bothered to take the time to actually be part of this webinar this evening. I'd just like to show you where my own thinking is at this particular week. We are facing, and I'm courtesy of Joanne Atkinson here, who's speaking briefly, and her modelling team for work they've been doing in the Northern Rivers of New South Wales, the extent to which we could use technology right now to better coordinate care for all people requiring care to impact on suicides and mental health presentations. And I simply want to point out that actually, if technology that's 21st century available was simply involved in coordinating care, actually directing right care first time, not excluding people from care, not triaging out of care, not restricting care only the most severe, that we could have profound effects on really important outcomes like suicidality and emergency room presentations. The next slide. The way you use technology matters. So what we say, no waiting list, and people go, no what? Of course there's a waiting list. In fact, with most of the state people I'm associated with, they say that's the way we manage demand. That's how a health system works most efficiently. No waiting list, you're not doing it efficiently. And I've been told that by many state directors over the years. Waiting lists are essential. People must wait, in fact, to receive care. So the proposition here is, in the 21st century, is that so? And that's what I'd really like to get into some debate about. Our belief is, if technology were used appropriately and combined with smart systems, the potential to meet the right level of care at the right time and provide the right interventions, pathways to better models of care, is entirely possible. It's just not practiced much. I was making a remark, I was doing a teleconference earlier today from the United States, and of course everyone hates the United States because they have managed care. What we prefer is chaos. Chaos results in waiting lists, exclusions, triage, and non-provision of care. Somehow, that's our preferred model. I think it's time we said, perhaps not, that we need to have an understanding of the systems in which we work and to model those. Now, I'm going to hand over at this point to Associate Professor Joanne Atkinson from our Statistical Modelling Unit at the Brain and Mind Centre, previously from the SAC Centre, just to show you, first of all, how smart she is. And secondly, actually, if you thought the world was tough, just get ready for the post-COVID-19 world. Joanne.
Just unmute myself. Thank you, everyone. So I think you'll see a slide that we've been working around the clock to take some of our existing models and run some scenarios of what might happen in these particular regions. And we took North Coast. We ran these kind of post-COVID scenarios on urban regional areas and regional rural areas just to see what might happen. And so we did a scenario where unemployment for the general unemployment rate got to 11% and youth unemployment to 24%. And we also assumed about a 10% reduction in social connectedness. And also a second scenario, a more pessimistic scenario of where unemployment rate, the unemployment rate gets to about 15.9% and youth unemployment to almost 35%. And you can see the devastating impacts that these scenarios could have on suicides. And what you don't see here is that there's impacts on youth suicide and on ED presentations, on psychiatric hospitalizations and other aspects of the service system. So we have a daunting task ahead of us, and sorry, I'm just going to having technical issues.
Are you trying to run it, Joe, or are you trying to move the slide?
I'm just trying to move, sorry, yeah. So, so we've been, thank you. We've been working with regional planners. So just to tell you a little bit about our work, we've been working with regional planners and their stakeholders in applying systems modelling and simulation to inform mental health services planning and suicide prevention for a number of years. And this is because health systems have so many moving parts, it's difficult to understand how investments made in strengthening one part of the system will play out across the system to improve outcomes at a population level and for different regions and different subgroups. And efforts to scale up programs and services can also be challenged by resource constraints, as we know, bottlenecks, inertia in the system and threshold effects. And so figuring out the right balance and scale and timing of investments across the different parts of the mental health system can be extraordinarily difficult without the use of systems modelling methods. And without these methods, sometimes even well-meaning investments in programs and initiatives can have very little impact or even unintended consequences when they're introduced into complex systems. And we saw an example of this in a systems model we developed for Western New South Wales Primary Health Network. There was 2 evidence-based interventions being considered in the region. They were GP training to improve diagnosis and referral for mental illness, and mental health education programs aimed at increasing help seeking. So when we simulated their combined introduction in the region, it resulted in an unanticipated increase in self-harm hospitalisations by about 5% and increase in suicide deaths by about 4% over the next decade. And interrogation of the model to try and understand why this was happening revealed that this combination of initiatives would generate more mental health service demand than the service capacity in the region would be able to cope with. And this increased rate at which patients disengage from services, so this increased the rate at which patients disengage from services because of increased wait times and dissatisfaction with the quality of care. And disengagement from the mental health system, which the local stakeholders that we've been working with in some of the regions, they called it the black hole. And so this disengagement from the mental health system increased the risk of suicide because people they told us that people lose hope that the system can help them, or experience further trauma from receiving inadequate care from an already stretched system. But the model also showed us, though, that if we get the balance right and if we achieve the right level of capacity increases in the right types of services at the right time, then these same initiatives could have positive impacts in reducing suicide in the region. Also, in other models, we've seen that there can be a combination of interventions or service strengthening strategies that work well together to reduce suicide behaviour or ED presentations or other outcomes. And anything introduced on top of that best combination delivers little additional benefit, suggesting that more is not necessarily better. So systems models can help us make smarter decisions about where best to focus our limited financial and human resources to deliver the greatest impact for the communities we serve. And in the same way that systems modelling has been used to inform our country's successful containment of the coronavirus outbreak, so too it can inform strategic responses to help us avoid the worst trajectories of mental ill health and suicide that we're seeing in those graphs. We need researchers working together with decision makers, engaging in disciplined, complex systems modelling work that's underpinned by the best available evidence and data and expert knowledge that we have, and local knowledge as well, and lived experience. Those perspectives are really important to the work that we do. And updated continually as new information comes to hand, and in order to strengthen their forecast capabilities.
Can I say, in the models you've been doing in terms of ameliorating these effects and other projected effects, can you just comment on, in fact, the role of getting to the right level of expert care in non-hospital settings? So you've kind of said, and the great thing about these models is no one's left out. It's not a matter of leaving people out of the model. In fact, if it goes badly, people get put in black holes and make the situation worse. They're not even on a waiting list. They're just sort of dumped into a no man's land. But also the importance of expert care. You don't want to end up in cul-de-sacs of nothingness or of low-level care that is ineffective. So more ineffective care doesn't help either.
No, that's right. And in some of the scenarios that we run, I don't have the numbers directly at hand, but we were playing around with, there was a combination needed of increased service capacity growth among mental health GPs, psychiatrists and allied health services, and community mental health. So it was a combination of things required, but also that there was a kind of a bit of a threshold. So I think a 20% scenario, a 20% increase in the growth of these services was not quite enough to kind of bend the curve. And so that we had to play around with different levels up to 50% to start to see a flattening of the curve. Okay.
So importantly, John Mendoza's just joined us and asking key questions about the factors we put into such models, including household income, definitely people requiring assistance, psychological distress, differently. These models can put in the basic socio-demographics, and in regional parts of Australia, these are different and they drive distress in different ways. Now, we won't go into the details of that right at the moment. Sebastian Rosenberg's asked about systemic incentives for non-hospital mental health care apart from MBS. So in a lot of these models, yes, the issue about actually what other factors can be modeled is a question of what people want to model and build in, including psychosocial support and other factors. So there are these models lend themselves to adaptation in that particular area, but not to get stuck on all the details of the modeling right now.
Yeah.
I'm going to ask to move along to Danny Rock, who's been working with trying to set up systems that do deal with populations, as he's worked through the Western Australian Primary Health Associations and trying to actually put systems into action. Danny.
Yeah, thanks, Ian. Can I have the next slide, please? So I thought I'd go through and talk about digital health and personalised treatment, because I think that's what the essence of this is. And starting with, you know, an unalloyed view of what the mental health system is, and to save us reading all 1,000+ pages, I've popped up the Productivity Commission's draft report, which basically says that service models don't meet the needs of patients, doesn't meet the needs of individual communities. Much of what is funded has indeterminate value, which it says 0 or low value, but also even worse is indeterminate value. And rather than being no choice, there's literally a bewildering choice, but people get lost in the system, and the system performance is opaque. And so my key messages at the end of this I'd like people to have is that the current system focuses on the average man models and produces suboptimal outcomes. And those suboptimal outcomes lead to expanded delay. Delay leads to priority setting, queuing, batching, and all other ways you might want to describe waitlists. And the individual preferences and need, capabilities and capacities are not routinely built into the system of care at all. And if we want to have personalised care, we need to have systems, established systems, that optimise individual treatment. And digital health is probably our best option for progressing this at this point. Can you go to the next slide, please? And there's a long way to go. This is the Commonwealth Fund, the US-based fund, who does a routine scan of primary care every year. And effectively, this is effectively the digital enablement of primary care for the benefit of patients in Australia. 2% of general practices can do the 4 basic functions, including allowing patients to see their own records. It means that we've got enormous opportunity to get it right, because we're starting from such a low position. Can you go to the next slide, please? And we have this step care model, which is again, it's a crude first approximation, I think, of proportionate provision, but it is no more than that. It's a very simplistic model, if you wish. And can you go to the next slide, please? So what I've done is I've taken, I took the data from the National Planning Framework, and I'm contrasting it here with what the 5th plan says. On the top, they're the population risk rates for various levels of mental disorder. The middle band is the expected treatment rate for those conditions, and the lower band is the proportion of people in an optimal system according to the 5th plan who would get treatment. It's a very flat picture. It doesn't seem to represent the hope for step care model, and I've superimposed that down on the bottom simply to and partitioned out where most of the care is. It's step care in its current kind of description doesn't produce the sorts of personalised care, I think, that we would wish to see in a system. In fact, it's not very much different if you were to take it forward from what we've currently got, with all the issues that Ian and others explained. Can you go to the next slide, please? And how do we address it? Well, what do we do? There's basically 2 things that happen. We either try to scale something up. We take something, we make it big, and it becomes placeless. And there are examples of this. Or we go to a place, we try to scale out, and we make it very, very place-based. And they seem to create tribes of, there's tribal affiliation to the 2 types of provision. And in fact, you end up with these kind of fidelity fetishists in the scale up, and you get kind of this outlier worship in the scale out. Everyone goes to Trieste. I love it. I've been there 3 times, and Trieste won't happen in Geraldton. But it's a nice place to visit. But and you have this false dichotomy, and I think digital approaches allow us to reconcile these two different positions, I think, and bring them together as a unified view. They're not an either or, they're a both. Can you go to the next slide, please? And in an editorial or a paper recently, Shane Cross and I tried to create a way to describe that both are needed, that the core scale-up platform is the carrying platform that provides the systematization of what we want to do. And the scale-out platform is the treatment in context and the localization, and that's the distinct components of care. And you bring them together. You bring the two together, and you do it in a way that actually each person becomes a data point in the system, not an average person. And then understanding that treatment optimization must occur in the real world, not in the lab, because in the lab it's a false world in which you are removing context. And if you want to have personalized care in the real world, you have to do optimization in the real world, not in the lab.
Danny, can I just interrupt you there? Because actually, yeah. Sebastian Rosenberg, my great friend, and for those who know us well, you know, when I'm Shrek, he's the donkey and he's the nice person. He's asking the question, isn't NDIS personalised care not going so well? You know, I think I'm on your team about this personalised sort of issue, but it's challenging, and other people say in new systems like the NDIS that that's what they've intended to do. And some would argue on the ground, it hasn't gone well. Do you have a view about that?
But I don't have I do have views about NDIS. I don't think I particularly want to broadcast them.
It's something that says it's got person at the centre of it. I mean, I say many things, but I don't think it has been delivered in a systematic way or as part of any system.
I think I'll get to something like that later. I'm fairly critical of halo models that, and everybody sees them if you were to put, if people want to bother, put person-centered care into Google and switch images, and you'll see a bunch of halo models. And I think if people think that drawing a person in the middle of the care system is the representation of personalized care, they probably need to try to work through the consequences of that, because that's not a system of care. That's just saying an individual matters, and everyone, that's a self-evident truth. What I'm talking about is the equivalent of precision mental health care, in the same way as my colleagues in genomics talk about precision medicine. So care that's calibrated to you, your preferences and needs, your circumstance and your capacities. And that's what I mean by personalized care. So precision care, P4 care. But
I think that's an excellent clarification. I think Sebastian and others are going to take that offline, because I reckon that's another, I say to the organisers here, that's another webinar in itself, because I think that issue about skilled right care for the right person isn't the same, as you say, Danny, for the notion that it's personalised and yet there's no system around that, and it's not actually skilled often to the needs. Okay, so on with the rest of your presentation, Danny.
The next thing is really getting onto that point, which is this issue about the famous point of optimality, which is often, well, if you're old like me, you would remember this kind of work, that there's a trade-off between harm and benefit, and that the harms accrue both at a population level but at a personal level in treatment, way past the point at which where the benefits start to plateau. And there's a sweet spot we like to have in treatment. And those points of optimality are the average point of optimality. The promise of digital health is you can have a personal optimality point, and that can feed back into the system. So that so instead of starting at the average and working out, you start at the person level and then develop the aggregate from the personal. And so that, again, every person is a data point in this potentially, and it's the sum of the people that are the population, not the population is just a divisor that you chop the people up into. And I think that's a critical thing not talked a lot about in digital health. It is perhaps the most personalized form of health you could possibly have, because you can't you're literally starting off at the point that it's people that you assemble up into populations, not populations you divide down into people. And I think that's a crucial difference that's not addressed. and we have no clue about the optimality points for most of the treatments we offer in mental health, none at all. And it's at a simple economic perspective, if you don't know the optimality points, you can't do estimate allocative efficiency, so you can't assign funds in any sort of manner except for.
Could you just comment a bit more about this, Danny? I don't think this is understood about the digital solutions, that they build up from every individual's experience to describe the population. They don't start with the population and say, you can have this many things down and you can fit yourself into what we are providing.
Yeah.
No matter how well-intentioned those different elements of care are that are top-down driven.
Yeah.
You know, so it does lead to a greater understanding of the variation in the population.
It's a massive, I mean, from a philosophical perspective, it's really important, but it's also practically important. So essentially what you're doing is you are signing up authority for your, you know, you're saying every individual has personal authority, and they may choose to assign some of it upwards. It's not handed down to you. You act up, and you're part of the sum. You can see that kind of. I was thinking the other day about this app that we've got around COVID. It requires everyone to sign up. It can't be an average model. You can't have an average COVID monitoring system. You have to have people, and the power of the model is the individuals in it, not the concept of it.
Now, Danny, for the sake of time, although I could personally continue this discussion with you for a very long time. A final point, perhaps.
Could you, if you just go to my last slide, it's not next, no, back, that one, yeah. So really, this is the point I'm trying to make: is that if we want personalised treatment, we have to move to measurement-based care. We have to that would maximise value for the person receiving the care and minimises the waste. And I'm hoping Shane might talk a bit about the waste. The ICT we need to support that is really a thin infrastructure. It's not very much, but what you actually need is real-time data capture, because that real-time data capture can fold back into the system, into the health ecosystem, and actually manufacture the forms of care you want using individuals' own response to their treatment, which is as close to precision medicine as we will get in mental health in my lifetime. And so we should seize the opportunity.
Yep. So everyone can potentially get the level of care that they need, and that level of care can be tracked over time. I think are the key messages for me, and I apologize for running in and out. Some things, for those who don't know, if you're really interested, some of this will be on the 7:30 report tonight, courtesy of Joanne, and there is some slight degree of media interest in the background. And in fact, the Minister, I think, has expressed his support for taking forward these kind of approaches. We are in really interesting times in mental health, and I think this is why we have a focus on these particular issues. So moving along next to Mike Millard from St Vincent's. The next two presentations by Mike from This Way Up and from Shane Cross from MindSpot is, okay, can we take certain kinds of structured interventions at scale where they need to go? You know, waiting lists in many areas has often meant a long trip to a big hospital in the middle of a city, because that's where the big treatment is. And we know that corresponds with distance from the city is the rate of death, is inversely related to that particular phenomena. So Mike and Shane, can we go the other way? Can we take treatments that work out at scale to people who may benefit from them?
Absolutely. So, I mean, I think it segues really nicely into, I think, the history of This Way Up. And I'll just kind of say a couple of words around that, in the sense that it really came from being embedded within a very busy inner city anxiety disorders clinic that was a face-to-face service that had a lot of waiting lists. And there was a long time for people to actually get into treatment here at the St Vincent's Anxiety Service.
And it's fair to say Professor Andrews didn't let you in very easily either.
I think that's just a vicious rumour, I believe. So I think so. It was a service with a lot of waiting, with a long wait list, and it started out thinking that Gavin basically thought, well, what we're going to do is we're going to take the best treatment that we're doing here, and we're going to put it in manuals, and we're going to give those manuals to other people so that they can start doing the treatment that we're doing here, so that they can start doing the evidence-based treatment or the cognitive behavioural treatment that the clinic was quite well renowned for. So then along comes this thing in around about, the year 2000 called the internet. And the clinic still had long wait lists, despite the fact that they were doing a whole lot of group programs, and the demand was there. So the decision was made, well, why don't we take the manuals and put them on the internet? And it is a really fantastic way of thinking that we're taking a scalable, tested intervention, and then we're going to make it available using new technology, or the internet as it was then, to essentially anyone who needs evidence-based treatment. So that's grown through to This Way Up, which was formed in 2011, and it's now formed into, we have 18 evidence-based, internet-based cognitive behavioural therapy courses, of which 11 are disorder-specific. I think that the things that make This Way Up different in terms of the approach is that Professor Andrews has always been around helping clinicians to be able to upskill and to apply the techniques that were known to be able to help the anxiety disorders. So if we kind of go to the next slide, I kind of talk about it being a clinical tool that's been built for integration. So the way that we use it, and we still use it this way in the ADC, is that if people contact us or clinicians want to use it, the courses are available as a standalone intervention, and we certainly have our self-help courses, and that's the majority of our users now do the courses as a self-help or recommended by their clinician. All of our face-to-face therapy is augmented by online CBT, and that's really around this idea of the flipped clinic that we kind of talked about before, where we use the technology to increase the efficiency of our face-to-face offerings. So we use the courses to teach the people the skills, and then we use our time as a specialist clinic to help the person apply the skills, which is actually the complicated part of cognitive behavioural therapy. The other way that I guess that the other thing that we do is that through our assessment process at the clinic, sometimes we do have a delay in people accessing face-to-face treatment because it's a limited specialist resource. And what we do is we get people starting to do the ICBT course first, so they get a feel for whether cognitive behavioural therapy is the type of treatment that they think that will be helpful for them, and also they start to learn the language of what therapy is. So sometimes people just do the online courses and they don't progress to face-to-face treatment, or sometimes through the integrated system that we have, we monitor the patient's progress as they progress through the course. So if the distress measures are going up, or if there's other safety measures that are triggered in the system, we're able to pull the patients in and to be able to manage I guess, to provide the additional assistance as needed. So I think that's the way that we use it here at St Vincent's Hospital, and that's the way that we want to support clinicians across Australia to be able to integrate these digital tools into their practice to strengthen their therapeutic alliance, certainly rather than to replace it. So I just thought I'd give you a little bit of an example of what we've seen over the last couple of weeks on the next slide in terms of this dramatic shift that we're seeing in terms of an interest in digital health and digital interventions. So I just flagged that since the beginning of the crisis, we've had a sustained 900% increase in course registrations, and it's equated to about 16,000 unique users that have come through over the past 8 weeks. Now, we had a staged response to the crisis because we recognised that, of course, that the first thing that people are experiencing are these increased levels of distress due to, obviously, the current circumstances. So we created some COVID-specific resources which were simplified and very accessible in terms of they were audio-based, and designed to not overwhelm people who were already distressed. And we were surprised to see that 12,000 people were accessing these in the first 2 weeks of them being available. Within that, we had a distress measure that people were able to work through the K10 and to get a sense of actually what the levels of distress they were experiencing, what we'd recommend. which I think then has fed into people who fed into the 900% increase has been in the disorder-specific course registrations, and the average baseline distress score has been severe when we've looked at the K10. I flag that I say that 30% of the people were from regional and remote areas. That's not a different number to what we normally see. The statistics have been the same. So it's just been an example of care provided on a much bigger scale. The numbers have been much bigger, but the ratio has been the same from what we would normally see. Over the same period of time, we've had 650% increase in clinician registration. So what that's meant is actually that people are starting to integrate these things into their routine care. And it's very small, but you can see that it's
that's actually clinicians using the tool,
yes,
or recommending the tool to their own clientele as well.
Correct, but that's not. It's a 650% increase in clinician registration. So we actually have a lot more people who are using the tool in their practice, and it's right across the spectrum. So we have psychologists, GPs, and there's quite the blue line in the slide. There is clinical social workers. So the stuff works. The stuff's being used, and it's actually a very exciting time for us to think that we can actually support and empower clinicians to be able to use these interventions to help to treat their patients.
And there's no intrinsic limitation to the amount that it can scale up in the system. Yeah. So at times when the rest of us have trouble getting 3 more people into a system in the week, or dare I say that in the past, one had to wait a long time till Professor Andrews excluded the person you had referred from the service as not being... that's not a criticism of Gavin. I mean, Gavin's obviously a major leader in these sets of areas, but this capability to take that kind of developed system, in that kind of responsiveness. So one of the critiques, I think, of many of our mental health systems is they are not responsive to crisis. They're not responsive to change. I don't think many of us could draw a graph like that, with regards to how our answers respond. Now, Mike, do you have a concluding statement to move on? Because my time management's very poor.
Sure. Well, I just want to say that we know the stuff works. And I really think that the biggest barrier for people getting it out there is familiarity. And that's what I'd encourage people to have, whether it's familiarity with us or whether it's familiarity with MindSpot, because, and you'll obviously hear about that from Shane.
Just on our way to Shane Cross, one of my favourite, in fact, of course, my favourite professor of psychology, because he's the head of school of psychology at Sydney University, Frans Verstraeten, has asked a question about, if we thought so much about this, wouldn't we have real-time app developers and real-time technicians working with us to adapt these systems along the way? Yes, Frans, we would. Now, we just have to convince people that this is essential health infrastructure. And of course, this kind of engineering, IT, data collection, as told this week, we don't collect data, we don't do metrics, is actually the health infrastructure of the 21st century. So of course, in the past, no. Now, yes. But actually how we build that in, I think, depends a lot on what Mike was just demonstrating, clinical leadership. That clinically, this is what we want to do and we can make it available. Now, Shane Cross, who has, run Headspace services for us, got his PhD with me. I'm sorry about that, Shane. I apologise for that. Has moved on to actually now being part of MindSpot with Nick Titoff at Macquarie University, which has very successfully been running on behalf of the Commonwealth. Clinician supervised CBT. Shane, waiting lists, got it figured?
Thanks, Ian. Yeah, thanks for that introduction. It was great to hear a lot more about This Way Up as well. In some ways, a complimentary service. But I'm here on behalf of MindSpot to provide an overview of what MindSpot does, similar to This Way Up, starting around the same time, 2013, MindSpot being an online digital mental health service that services roughly 125,000 people since it first began, equating to about 20,000 people per year. And interesting to see Mike's data as well, similar data for MindSpot, that 40% of users are from regional and rural areas. It's a free service funded by the Department of Health, and it essentially gives people an option to do online assessment and report feedback, as well as accessing a range of cognitive behavioural treatments online, be they self-managed or clinician supported. The COVID situation's been interesting for MindSpot as well. So MindSpot's also experienced significant increase in demand, 80 to 100% increase at least, But what's interesting is that a lot of people are reporting high levels of distress. It's not necessarily equating to higher levels of disorder. But as Joe and others have already mentioned, we might see those effects occurring further downstream in time with higher rates of disorder over time. If you can go to the next slide, please. Grace, I think, is running. Thank you. This is just an overview on the services MindSpot provides. The first option is around the public website, public-facing website that anyone can access, get information, do symptom quizzes, that type of thing. It's accessed by over 500,000 visitors per year. Lots of phone calls, there's phone-based support within that. Moving to giving people an option to do an online screening assessment, accessed by well over 20,000 people per year. A written report is provided directly to the consumer, and if they choose to, they can share that report with their health professional. I'll mention it in the next slide, but at the moment, 90% of people coming to MindSpot self-referred, 10% are referred from a GP. And what we see is, in that process is people doing these assessments, getting these reports, sometimes sharing them with their psychologist, with their health professional. You do see big proportions of people not currently accessing mental health services. And sometimes this is a way for them on point 3 there to get a sense of what their needs are, and if they're not engaged in care, find an appropriate local service that matches their needs, or go into point 4 there, the dedicated online treatments that in some parts are transdiagnostic, others are disorder specific, depression, the range of anxiety disorders and pain. We won't talk about this in detail. I mean, I'm very interested in the efficiencies that digital healthcare provides. And if you see, for an example, the data that Nick and his team have collected over a long period of time is around cost per patient, cost per episode. And an example like this, the average cost based on these numbers of people being treated is about $300. And you can compare that to the cost in MBS treatment. I'm a clinical psychologist by background. That cost ranges and it costs the government between what, $500 and $700. Other people can correct me if I'm wrong there, but you see big cost and efficiency savings in delivering treatment in this standardized way, producing strong outcomes, 50% symptom reduction, 40% disability reduction. If you can go to the next slide, please, Grace. Thank you. The consumer profile, we see people right across the age range. Interestingly, in recent years, we're seeing a strong increase in the number of young people using these systems. And as part of our development work going forward, we will expand the range of treatments we offer and the ranges those treatments are offered. Similar to what Mike was saying, I think it's an assumption that people use these online services when they have mild symptomatology, but similar to what Mike was saying, MindSpot also sees people in the moderate to severe range, and a significant number of people express suicidal ideation at service entry. Again, I mentioned service use. A lot of people that access MindSpot have not ever spoken to a health professional about their mental health concerns. And similar to what Mike was saying, when you see the outcomes, they're captivating really to think that of those high numbers of people that complete treatment, you get big symptom reductions, disability reductions, big effect sizes, and those effects are sustained through to follow up.
Just before you skip on, Shane, there's a question from Alana Fisher about the significant dropout shortly after course registration. Is that high levels of interest, but really low levels of engagement? And the earlier slide, we did see that go over to the other side. And, you know, only a relatively small proportion in the MindSpot thing appears to go onto the active treatment.
If you want to go back to the previous slide, because it's a good point. I've been at MindSpot now for 3 months, working through service development and thinking about ways in which the technology can actually increase personalization. That was something that struck out for me. But when you think about that, and what I like about it actually, it's all about personal preference and choice, is that people are voting with their feet. That's what they want. They want assessment. They want assessment feedback, actually, feedback that's transparent and open. And then, as you can see between point 3 and 4, they're given options. The clinicians that work at MindSpot go through what those options are for consumers after they've done those assessments, and it depends on what meets their personal circumstance. And you can see that because there's such a high rate of severe symptomatology there, it's sometimes in that person's best interest to see a local health professional, be connected to a local service.
Right. So
but sometimes they choose the online treatment.
I'm going to warn Liz here and Angelo Virgona as the two psychiatrists. What do you make of that? Actually, people want assessment. Fancy that. Fancy that.
And they don't just want assessment, because we give a lot of people assessment, right? And you and I have worked on this for a long time, Ian. It's about transparency. It's about giving people feedback. It's empowering people to better understand what's going on for them, get a sense of where they sit in the spectrum of ill health, and give people informed choice.
So I'm told every day of the week.
Options.
I was told 3 times this week, people don't want standardized assessment. People don't want that kind of instrumentation. They just want their personal narrative or their story to be understood. What do you make?
I think, well, they do. They do. But if we compare that to other areas of medicine, I'd like standardized care in other parts of my healthcare. You know, if I had cancer, if I had some other chronic disease, I would like to have faith in what was being assessed and faith in the treatments that were recommended and offered to me.
And you can take it elsewhere. You can actually show the assessment elsewhere.
And you can take it elsewhere. Exactly. It should be transportable.
Yeah. Okay.
Yeah, and my final point, Ian, is I think that the thing that digital health, in terms of the promise, is primarily around value. Danny mentioned this issue before. I think value is really about the benefits gained for the burdens endured. And if you can reduce the burden of treatment by reducing transport, reducing costs, out-of-pocket expenses, the amount of time I've got to go to a face-to-face session, and I get benefit, and those benefits can be realised in a digital space as well as they can be realised in a face-to-face space. All health, integrated healthcare should really be driving towards value.
Do you think, and that'll be slightly more challenging because I can with Shane because I kind of know you. I have raised the issue with MindSpot myself. I love the assessment bit, but is it a bit tight to get in? Is it a bit too clinically supervised to get into the other side of the bifurcation?
I wouldn't say that. I would say it's thorough. I'd say it's thorough, but I would also say that there's no doubt there's room for improvement. Technology is moving at a fast pace. We're looking at ways in which we can be more efficient. To the scaling question, and to Danny's point, it's not just about scaling up, it's about maintaining quality while scaling out and up.
And to you and Mike, because the danger is, you know, you both could be seen as things that get funded, and I love the maps, they get taken, Bits of Australia gets services that are real services that never really get it. But are you part of a system? In one sense, you've risen above regionality, you've risen above particular things, but you know, people still are part of more ongoing systems of care and a measurement-based care. How do you see yourself into systems?
It's funny you're mentioning the word system, Ian. I think there's a lot of agreement that there is no system. We call it a system, but it's not a system.
Fair call. Okay, fair.
And so when that system's created, I think that's also the promise of digital health is it can be the glue. And we need to actually de-silo a lot of what we do, both in face-to-face sort of service environment and the digital environment, and actually create a system that will be lovely to see.
Now, Shelley Rowe, who is from regional Australia, I know Shelley's from the North Coast, she's asking, that's great to see the rural and regional, but actually to other vulnerable populations, I wish she bids male, which I particularly like, but Aboriginal, Torres Strait Islanders, people without housing, other groups, do these sort of technologies actually connect with very at-risk groups who are, of course, most left out by the current clinical systems?
I've got a personal view on that. I think we've got a lot.
Danny, I think, is going to have data on that. Danny, is there an answer?
Well, we operate a system called Ports, which is the kind of that it's also operated by Macquarie and Nick Titub's group, but ours is a GP referred psychological therapy system. So I can tell you, and we map very thoroughly who is going in through that system. 7% of our patients are Aboriginal in that system. This is a high volume, 7% of the referrals. We look at people by their socioeconomic position, and of course we recognise that people mightn't have access to a phone or they mightn't have access to the internet. But when we look by IHAD status, which is by the household poverty index of the person, we are strongly biased towards people who are more disadvantaged. And
so is that by design, Danny? Because a lot of digital services, and I think a legitimate critique of a lot of online services, and certainly the trials, is tend to have a lot of women from higher socioeconomic groups. So how have you done that before we move on?
So we ask GPs to refer people for whom this service would be an advantage, because MBS, accessible psychology, doesn't work for them. And
Fancy that.
an expert at the front of the flow.
Yes.
We rely on GPs and equivalents to make a considered clinical judgment of the patient that's
right. Does anyone remember, now this may be a John Mendoza question, does anyone remember divisions of general practice before we had better access who were to actually preferentially provide psychological services to those who would not get into the MBS? And for those like myself, an original director of Headspace, was to go to areas where there was not NBS related practice. I mean, it is interesting that at times we tried to use a more regional approach, and generally speaking, it's then been undone by our subsequent MBS. So look, Shane, just to move on in the interest of time, so Elizabeth's sitting next to me. I'd ask her, and this is really for her and Angelo, okay? All these digital systems, and you just emphasised it, Shane, and Danny's question, go to better assessment. And I've been asked just today from Canberra. So, the psychiatrists, are you prepared, Elizabeth, to do more of the assessment up the front using digital means or others? Because the biggest waiting lists we know are for more specialised care. And in some places in Australia, there's no waiting list because there's no psychiatrist anyway. There's no one up there actually supervising that end, or clinical psychologist, or mental health nurse. So if these systems, Liz and then Angelo, are going to work, Liz, does your system actually do that?
So I'm looking behind me now to see where's the team who are going to stand behind me to provide a lot of these services at scale. So I think the challenges are to, as Shana said, to take advantages of the benefits that digital platforms bring, and not just simply use digital technology to continue to do what we do and think that that's good enough and we're doing a good enough job. If we are going to do the things that Danny has talked about in terms of calibrated care and precision-based care, if we're going to improve access and quality, if we're going to be able to provide value in health systems, then we really need to take this opportunity to try and do things differently. So I'm very now happy with my capacity to use Zoom. We've incorporated this way up into our inpatient service. I think today we've started that. That's been a long time coming, but we finally got there, and into our outpatient practices. So all of those things are, as Mike has shown, a rapid transformation of services, which is a huge, step forward. Clinicians are incredibly resistant.
You mean technology. A hospital might actually provide standardized care?
A hospital.
Oh my God.
And be able to track outcomes in real time and be able to feed that back into patient care. So all of these things about kind of better integrated care, better value, and being able to look at and being able to kind of manage waiting lists better. So we're involved in a program.
But not manage waiting lists. What about no waiting lists? What about you do the assessments up the front? People don't wait 8 weeks, 10 weeks, 12 weeks, never.
Yes.
Broken Hill, the psychiatrist used to fly in from New Zealand once a month. What about the actual, we need skilled clinicians, MBS or not, payment systems or not, to actually be in these systems at those key points. I think the complexity issue, and perhaps what Sebastian was also driving at, to actually be part of not just talking about the personalised system, picking up Danny's point, to provide the skill and the precision. Do you think you can do that in partnership with these new systems?
So I think skills, are an issue. I think we lack the training. We lack training in clinical medicine in using digital technologies. I mean, there's no doubt about that. And I don't know that, Mike, that we've really advanced our training in these areas for new clinicians coming through. I think this will be the opportunity to model some of those systems and do that. What we can see is the capacity for people to adapt rapidly. One of the capacities that makes us highly successful as humans is that people have taken on. So the old, clinicians who I work with who still were writing on paper have actually been able to utilize technology, provide, yes, and with pens, and do things that they would not have said they could do or would want to do. And the feedback that we have from our patient and our clients is that, with some exceptions, they feel more relaxed, they feel more comfortable, they really don't see that there's a huge gap in the service that is provided for them. The challenge will be to change our practice, to put more of the assessment up front, to be able to utilize technologies to be to have people.
And not to exclude people from care. I think one of the things we were discussing these particular things is not putting the psychiatrist up the front to say, no, you can't come in. Like, I was being rude about Gavin, and I love Gavin, so I don't want to be rude about this, but I can think of about 20 of the greatest clinics in the world where the role of the really skilled person at the front was to say, you can't come in, because we're actually only going to take, those who respond to what we do. The specialty of the house is treatment of social phobia or treatment of OCD, or where I used to work, treatment of treatment-resistant depression. And unless you've got the specialty of the house, you can't come in that particular house of God type way. So in this system, it's not about, correct me if I'm wrong here, Liz, or it'll come to Angelo, about you can't come in. It is that you will get what you require, even if I can't do it.
So systems train us to be gatekeepers. They train us to think about the capacity that our system has, and we have all had scarce resources. So that sense of being the expert gatekeeper as the senior clinician is a concept that we all grow up with and learn how to do. We have to unlearn that actually this is about how do we develop capacity, how do we take services to scale, how do we use our expertise to be able to make sure that people get the right care at the right time, that they are escalated.
First time, right? First time.
That they are escalated,
no waiting list.
That they are escalated up into the appropriate level of care. So the response that we get from services with all, with all well-being is we don't have the capacity and we will get overwhelmed. So we will not be able to cope and we'll get overwhelmed.
Do you remember Joe's curve? If you're feeling overwhelmed now, just wait in the post-COVID-19 world.
Yeah.
And who's going to get that care and isn't. Now, we're almost out of time, and I've tried to answer questions along the way, but my favourite psychiatrist, other than Elizabeth, of course, is the very attractive Angelo Virgona from the College of Psychiatrists, and perhaps a man of my age and immaturity. Angelo, is the rest of the team up for the team at the College of Psychiatrists, the professional organisations who've historically been seen as one of the barriers to progress? Are they up for this? And I must say, Angelo actually is out there on the front line in southwestern Sydney and the Southern Highlands, sometimes lone warrior, I think. Angelo, can we do it?
Sorry, I'd muted myself. Of course we can, Ian. As Liz pointed out, there's been an incredible uptake because of the necessity over the course of the last 2 months in people using online platforms. And I think that's been very encouraging. I think I speak to hundreds of psychiatrists in New South Wales daily through online platforms, and Victorians as well. And the thing about psychiatrists is they really hate working in a sick system. And they've been working in this sick system for a long time. And people will say, oh, well, you're resistant to change. Well, no one's offering us an alternative. So there's no alternative to what we've got at the moment. But if there was an alternative where people could operate in a much more effective and coherent way for the population, well, then I think psychiatrists would jump at the chance. And so we've seen this uptake with the digital platforms. We've also seen a lot of work over the last few years through the primary health networks, where they've got little bundles of money to look after people with chronic and severe disorders, and using innovative ways of getting psychiatrists to perform assessments, 291 type comprehensive assessments. So that I had a slide there that you don't have to put up, Grace, but the slide just was one that I stole from the Mental Health Commission in New South Wales, and really tells the journey of a girl who ends up with an appalling outcome, and all the points along the way where differences could have been made. And I asked the Commission actually if they could do a slide for this for all sorts of different disorders, because I think all of us, we read something like this and we all know patients like this who've had an appalling outcome, and there are so many points along the way where we could have provided the precision type care that Danny says, but they just don't get it. Psychiatrists would love to be involved in a process where we can get in early, we can give people a comprehensive assessment, we can work with a team, as Liz was talking about, to come up with a comprehensive care package for people and move on. And you do that, you're going to get so much more efficiency. You won't get these, $1 million bills at the end of a pathway for patients who are having poor outcomes. We're able to actually deliver the right care at the right time. So I don't think there'll be resistance. I think there's a lot of psychiatrists who are willing to jump on board sort of exciting developments.
Look, and it's a great slide to leave up at the end of this particular thing, because going back to Danny's point, I think one of my own essential points, measurement-based care could have averted that red path at any point. I often say to people every day, maybe it's just my own practice, I don't care whether people get better. I care when they don't get better or they get worse, that we actually have the capacity to review what is actually happening. Our prior predictive value on a one-off may be not that good, but as we follow people over time, we can do. And I think the issue here is actually expertise and skill, along with the person, the user-reported journey and of their families and of others tracking these particular issues. And the system is one of tracking. I think my final comment, I'm very grateful to all the speakers this evening, and those, and particularly Sebastian Rosenberg and John Mendoza, whose questions have been endless and funny, is actually we do now have the technologies where we can build the system, and the clinical leadership in those systems, I think, is absolutely essential. In future webinars, we'll return to some of these, but I did really want to take the time this evening to show some innovations in this area, people who are thinking about systems. There's a willingness amongst clinicians. The current challenge, I would argue, is the current opportunity. If not now, whenever. If we don't do it now, in my view, we'll have fundamentally failed in the reason that we actually do the work that we do. And there is a willingness in government, a willingness in the nation, a willingness internationally to say, now's the time to use 21st century tools, systems in which our clinical skills and our understandings, and the final thing Sebastian had along the way, our essential humanity is driving, trying to abort that trail that you just showed at the end there, Angelo, and that our capacity to do that through skilled interventions, timely interventions, and a willingness to be accountable for the interventions we provide is essential. For the rest of the audience, you can see where a lot of this has come from, where a lot of the other resources are. There was another question along the way, and I have to ask John Mendoza this one, about online resources for ACT-type therapies and for other things. We've only picked a selection of that which is available here in these systems. At the moment, there are many others. We're happy to take further questions and considerations, and we'll notify you again of the future. We're very grateful to those people who support us in this particular work through Sydney University, also through Bupa Health Foundation. It might surprise you, the insurers would like to see a considerably better system, but also through entrepreneurs in this area, particularly Future Generation Global, who cares about the future of Australians. And they're from the financial services market. And guess what they use? Predictive models. You know, and they make money out of it. I think we'd like to see people lead better lives as a consequence of using data in smarter ways. Thank you very much for your attention this evening. For those who are looking at us live on Wednesday night, I suggest you go straight to the ABC and Norman Swan to see the 7:30 report, and actually hopefully commitments of our own government to taking this forward. I think this is the time for digital health to demonstrate it's an essential enabling tool, and waiting lists is such a 20th century idea. Time it ended. Thank you very much for your attention, and good night.